Hello and welcome everyone. Thank you all for coming to the fourth of five webinars brought to you by the Capital Health Network and obesity physicians in the ACT, Dr. Carol Huang, Dr. Richard Singer, Dr. Louise Brightman, and Dr. Deborah Inman. Tonight's topic is obesity, impact on sleep, dyspnea, renal function, and liver disease. The three previous webinars are on the Capital Health Network YouTube page, and this webinar will be uploaded to the YouTube page soon. We're also holding a fifth webinar on post-bariatric care and long-term complications on the 7th of September, so make sure you register for that too, because the 5 webinars give you a really nice package on how to manage obesity in the primary care setting. First of all, we'd like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region, and we pay our respects to their elders, past, present, and emerging. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, the GP Education Advisor at the Capital Health Network. Also with me tonight are Dr. Carol Huang, Dr. Richard Singer, and Dr. Louise Brightman, and Kanal from the Capital Health Network. So housekeeping, as always, all participants have been muted, and please type all your questions into the Q&A section in your Zoom panel, and we'll have the question and answer section at the end of the presentation. We'll send copies of the slides to you at the end of the event, and a recording of the webinar, as I said, will be uploaded onto the Capital Health Network YouTube channel in the coming weeks. So this session has been accredited by the RACGP for 1.5 hours of CPD for educational activities. If you'd like CHN to upload those hours for you, please send us your RACGP number and the completed post-event evaluation survey by the 10th of August, and we can register the 1.5 hours for you. Our first speaker tonight is Dr. Carol Huang. Carol is a respiratory, sleep, and general internal medicine physician and works as the Director of Respiratory and Sleep Medicine at the Canberra Hospital and also privately at RSCM, where she consults on sleep and obesity medicine. Her main research interest is medical obesity management and non-invasive ventilation and pulmonary physiology. Carol has scope certification, and she'll be talking about the impact of obesity on sleep quality, sleep apnea, and also obesity hyperventilation syndrome, which is not often that well discussed in general practice, and incidentally used to have the quite cute name of Pickwickian syndrome. So over to you, Carol.
Thank you, Leonie, and thank you to the CHN for inviting me to speak. So today, my talk is titled Breathing, Sleep, and How It Relates to Obesity. And see if I can. Letting me scroll forward. Here you go. Okay. So the learning objectives for today's talk is hopefully by the end of the talk, you will be able to describe how obesity affects lung function and how this contributes to breathlessness. And we are going to be able to describe how sleep deprivation and circadian disruption leads to weight gain and metabolic dysregulation. We should be able to also describe how obesity contributes to the mechanism of obstructive sleep apnea and identify the clinical features consistent with obesity hypoventilation syndrome. And finally, I'd like you to be able to describe the importance of early identification of obesity hypoventilation syndrome, because this has the potential to prevent hospitalization and has impact on morbidity and mortality. Okay, so we're just going to start with a case, and this is a real patient who I have seen for quite some time. So her name is Mrs. T, and she's 75 years of age at the moment. And she came to see me a few months ago and complained that she has had issues with increasing dyspnea and chronic cough since she had her COVID-19 infection in March 2022. And this is on a background of chronic dyspnea, which she has been complaining from time to time. And she reports declining exercise tolerance and can hardly get to the letterbox at the moment. Now, I have known her for quite some time now, having met her at the Canberra Obesity Management Service back in 2017. And at that time, she was diagnosed to have a severe obstructive sleep apnea with an apnea-hypopnea index of 104.8 per hour, and her oxygen saturation was known to go down as low as 56% during a sleep study. And so she was diagnosed to have obesity hypoventilation syndrome, and we have treated her with CPAP since 2017. She also gave a history of that she might be concerned about whether she had asbestos exposure, as her husband has passed away from asbestosis, and she had washed his clothes all her life. She was diagnosed to have ischemic heart disease in 2017 on presentation to the Canberra Obesity Service, and she had previously reported dyspnea and lethargy, and the ECG in fact showed ischemic changes, and underwent a coronary angioplasty to the left anterior descending artery back then. Her current weight is 124.4 kilograms with a height of 1.53 meters, giving her a body mass index of 52.3. So how do we sort this out? I think you would agree that there are a number of possibilities, and this could potentially be explained by ischemic heart disease. She's known to have that already, and there's no reason why she may not have had some progression of the disease, or has she actually got uncontrolled obesity hypoventilation syndrome? Could this be due to asbestosis or interstitial lung disease? Or has she got COVID and, not with persistent symptoms? Or is this something new? Or is it just a severe obesity? And this is gives us a segue to discuss what are some of the things we need to know about obesity and breathing, so that will help us to sort this out. So in terms of obesity and lung function, I think the important things to know are that people with obesity are at increased risk of respiratory symptoms, such as breathlessness, particularly during exercise, even if there are no obvious respiratory illness. Obesity means patients have more tissues, and that means more cells that requires oxygen. So obesity by itself actually increases the oxygen consumption and carbon dioxide production even at rest. And in addition to this, the respiratory system is actually more stiff, the chest wall is heavier, and the mechanical work for breathing is increased. Now, we use body mass index as a global measure of body mass, but this doesn't actually account for differences in distribution. So whether you are pear-shaped, which results in mostly fat on hips and thighs, versus sort of apple-shaped, where most of the fat is in the torso, can have significant implications in terms of respiratory mechanics, and hence heterogeneity in terms of changes in lung function in obesity. We also know that the reduction in lung compliance is exponentially related to the body mass index. But in a person with significant obesity, it also leads to increased pulmonary blood volume, and particularly in dependent parts of the lung, because of the reduction in lung compliance, the small airways tends to close, leading to small areas of atelectasis. And in addition to this, the patients have increased alveolar surface tension due to a reduction in the functional residual volume, and therefore, this can result in reduction in lung compliance. Now, the chest wall compliance is actually also reduced, but the mechanism of this is unclear at this stage. So what happens to airway function in obesity? The FEV1 and FVC tends to decrease with increased BMI, but the effect is generally quite small, and both are usually within the normal range in healthy subjects with obesity. So when you actually see pulmonary function test that comes back that sort of says, look, FEV1 and FVC are 60% predicted, and this is due to obesity, one will have to take a careful think about whether that's indeed the case, or perhaps there is actually pathology underlying all this. The mechanical properties of the airways are highly dependent on lung volume and on the caliber of the airways, and the resistance is increased with reduction of airway caliber. So on the right-hand side here is the flow volume relationship. And for a person who is of normal weight, generally speaking, this is the lung volume. And then as people breathe in and out, they breathe into the total lung capacity, and then as they blow out, this is the relationship between flow and volume. And in a patient with obesity, the total lung capacity is reduced because they have a heavier chest wall, but the residual volume does not change an awful lot. So the flow volume curve actually looks slightly different. But also more importantly, just in sort of quiet tidal breathing, these patients, rather than having a flow volume loop that's in the middle of the maximum flow volume loop with lots of space to expand on other side, these patients tend to breathe at a much lower volumes. And if your flow is approaching the maximum flow volume curve, because it doesn't take much to do that at this part of the lung volume, then you're much more likely to feel short of breath. So the tidal volume is often reduced in severe obesity, but usually at rest, it's usually normal in mild to moderate obesity. But so the residual volume remains the same. The tidal volumes reduced somewhat, but the patients are generally operating at an end expiratory flow volume that's actually lower compared to a person who has a normal weight. So the breathing tends to follow a rapid shallow pattern, and this is in response to the increased stiffness of the respiratory system. And this is not too dissimilar to what you see in bronchoconstriction, where there's an increased elastic load. So people adopt this breathing pattern that's rapid and shallow. And the functional residual capacity is close to the residual volume. So when you're breathing at a much lower volume, the airways are much more likely to close, and abnormalities in ventilatory distribution then occurs, and this actually occurs proportional to the severity of obesity. And when you see premature closure of the airways, then that leads to VQ mismatch, and that results in mild hypoxia, and the air gradient is increased even in those who have a normal carbon dioxide level. And most suggest that the diffusion capacity is actually normal even in severe obesity. So breathlessness in obesity is quite common, and the mechanisms are not well defined. Now, peak exercise capacity is usually normal in healthy subjects with obesity, but the oxygen consumption and minute ventilation is greater in those with obesity because there's more of them requiring more oxygen. But we also know that moderate weight loss of about 8% is associated with a reduction in oxygen consumption due to a reduction in respiratory muscle work by about 26%. So when you reduce the oxygen consumption to the respiratory muscles, then people tend to have, they're usually able to increase their exercise capacity. The risk of asthma also increases with BMI. and the odds ratio for asthma is 1.5 for those who are overweight and 1.9 for those who has obesity. And prevalence of obesity is higher in those with COPD compared to those without COPD. So these are just some facts about obesity and how it relates to breathing that I thought might be interesting to all of you. Okay, now we're going to change gears and talk a little bit about sleep and obesity. Now, a lot of the times when we consult our patient and and they tell you want them to lose weight by increasing physical activity, and they tell you they haven't got time. Sometimes a common response is to say, look, can you wake up early and go out for a run or go to the gym? But we need to also remember that short sleep duration is associated with obesity. And that's also been shown in children and adolescents as well as in adults. And the risk of incident obesity is 1.15 times for those reporting sleep of less than 5 hours compared to those who report a sleep of 7 hours in the nurses' health study. Now, later sleep time is also associated with obesity. So 9 hours are much more likely to have issues with obesity. And so perhaps this is related to shifting of the timing of the eating patterns. And obesity has been associated also with daytime napping and lower sleep efficiency, and the sleep quality has also been shown to be affected in those patients with obesity in some studies. So I want to spend a couple of minutes just talking about the clock genes, and this is actually a fairly new sort of development that's been, but we're starting to understand a little bit about how the body clock actually works. So the clock genes has been discovered quite some time ago now, and the actual clock gene seems to serve as the basis of an intracellular timekeeping system. And the main clock genes are clock and BMAL, and these two genes interact with each other and produce a number of products. And these genes are expressed within the circadian pacemaker, which is in the suprachiastic nucleus, as well as in many other tissues. And the expression of the clock gene actually generates approximately a 24-hour rhythm in physiology and behavior. So the sleep loss can actually affect the expression of these clock genes outside the suprachiastic nucleus, and it's been shown to affect a range of things, including metabolism, immune response. Cancer can affect your microbiota and also can have cardiovascular effect and leads to premature aging when you have dysregulation of the clock genes. So the disruption of the clock genes can occur and leads to recurrent disruption of daily activity rest rhythms. And then when this happens, it has been shown to be associated with change in feeding patterns leading to metabolic syndrome. The disruption of clock genes have also been shown to be associated with obesity, hyperinsulinemia, and diabetes. And the clock genes have been found to be involved in hepatic gluconeogenesis, lipid and cholesterol metabolism. And these are some of the effects of disrupted clock genes. So they can not only give you a poor sleep, leads to mental health issues, and perhaps leads to dementia. There's metabolic consequences of disrupted clock genes, where there's a dysregulation of the different microclocks around the body. It can lead to changes in microbiota, leading to increased body weight. There's now evidence suggesting this can also lead to atherosclerosis and cardiovascular risk, as well as stress response leading to premature aging. And there is also suggestion that clock mutation can lead to chronic jet lag, which then leads to enhanced cellular proliferation and promotes tumor formation. So what are some of the consequences of having inadequate sleep or having sleep restriction? And I have to actually sort of acknowledge Dr. Deborah Inman for giving me her slides. So there's definitely small laboratory studies that shows sleep deprivation is associated with hormonal changes, and it leads to decreased leptin and increased ghrelin. And ghrelin, as you know, is a hunger hormone, and then this leads to increased hunger and with an appetite that favors calorie-dense, high carbohydrate content foods. And it also is known to be associated with increased evening cortisol level and increased HOMA level post breakfast, which then leads to glucose intolerance and decreases the insulin sensitivity. At the moment, the meta-analyses haven't found consistent findings in humans, but there's a significant heterogeneity in the studies, which may be the reason why we haven't been able to have consistent findings. But there is some evidence that in the states of sleep restriction, there's enhanced susceptibility to overconsumption. And the neuroimaging suggests there's activation of the pleasure reward pathways in response to food. And the energy expenditure is slightly increased, but despite that, there seems to sleep restriction is associated with a net positive energy balance. This is a meta-analysis of all the studies that have been done about sleep deprivation and how it relates to weight. And as you can see that with all of the studies, with the exception of a couple of studies, there has been shown that habitual sleep of less than 7 hours duration actually predicts a future weight gain. And this is independent of baseline weight. And there is good meta-analysis data suggesting that short sleep duration is associated with obesity. So think twice the next time when you tell patients to get up an hour early so they have time to exercise. So what about circadian disruption? Circadian disruption experiments are actually quite difficult to do, and they are usually done in small numbers in a sort of metabolic lab with where you can control the light and to actually try to sort of result in forced dyssynchrony of the body clock from the actual daylight and so forth. And if you actually use a forced dyssynchrony protocol to invert someone's sleep-wake cycle and fast and feeding cycle by 12 hours, then it has been shown that this has significant metabolic consequences leading to inverted cortisol and melatonin profiles. And then this has been shown to increase postprandial glucose, even though you have more insulin. So despite that you are producing more insulin, you are actually having more glucose, suggesting that you have insulin insensitivity. And the leptin levels are decreased, and the sleep efficiency is also decreased. The timing of the food consumption is later than associated with weight gain, and this is also associated with metabolic and behavioral changes. So restricting food intake to daytime is associated with weight reduction, which has been shown by Gill and Panda back in 2015. And this has also been shown to be associated with improved outcome post-bariatric surgery. What about shift work? I mean, as doctors, many of us do shift work, and some of us have done chronic shift work. Now, night shift work is associated with an increased risk of obesity and overweight by about 23%. These people who do night shift work have more light exposure at night, and this leads to and also during the day, I guess, when they're trying to sleep, and that leads to more sleep disruption. And as a consequence of that leads to sleep deprivation and accumulative sleep debt. And there is a exposure response relationship between the intensity of night shift work. So for example, how many years you've worked and the number of night shifts you work per month to the risk of obesity and overweight. Okay, so let's change gears again and talk a little bit about obstructive sleep apnea. So as all of you know, that obstructive sleep apnea occurs when you have a frequent collapse of the airway, of the upper airway during sleep. And when the airway collapses, then you end up with oxygen desaturation, and that can lead to sleep disruption as well as change in sympathetic activity. And obstructive sleep apnea leads to sleep fragmentation, frequent nocturnal awakenings, and ultimately can lead to daytime sleepiness and fatigue. And it is well known that OSA is associated with substantial societal cost, not only through healthcare utilization, but also through reduced quality of life, as well as reduced workplace productivity. Now, OSA prevalence is estimated to be as high as 45% in those with obesity. And we have some local data from the Canberra Obesity Management Service, and this was published in Obesity Journal back in 2022, showing that the actual prevalence of OSA in our cohort of patients is as high as 70.9%. And the Canberra Obesity Management Service uses a universal screening strategy of all patients at the time of their initial medical assessment, and our mean BMI for all of our patients is about 50.1 kilogram per meter square. And we know OSA contributes to sleep fragmentation and sleep deprivation, and has been shown to be associated with glucose intolerance and insulin resistance independent of obesity, and can be associated with heightened systemic inflammatory state. So next time when you see a patient in your practice with moderate to severe obesity, it's worthwhile asking about the sleep-related symptoms. And certainly we find that of the 70.9% of patients with obstructive sleep apnea, more than half were actually diagnosed at the Canberra Obesity Management Service. So it's something to think about. So why does obesity lead to obstructive sleep apnea? There are a number of reasons why people might have a collapsed airway. And these are some of the factors that determines whether your airway is open or closed. So the airway collapsibility is, can be affected by nasal resistance, the size of the airway, as well as the upper airway muscle tone. And obesity or weight has effect on a range of these things, and it's thought about obesity. It probably contributes to 50% of airway collapsibility, along with other factors such as the size of the airway, which probably contributes to 25% of the airway collapsibility. So if we can help the patient reduce their weight, they will have their airway will collapse a lot less. And the size of airways may also increase, which leads to less collapsibility as well. So OSA and obesity has a bidirectional relationship. So with obesity, it leads to an alteration in airway anatomy and changes the pressure required to collapse the airway, which is known as PCRIT, and is a measure of airway collapsibility. Also, obesity destabilizes the respiratory control center and changes the loop gain, and leads to also to reduction of lung volumes. And there are also some effects of neurohumoral mediators such as leptin, which has an effect on ventilation. And this then in turn leads to obstructive sleep apnea. But obstructive sleep apnea by itself can actually also lead to obesity through the modification of a dietary intake as a result of the sleep loss. It can actually affect the gut microbiota with disruption of the clock gene through inadequate sleep. It can change the energy expenditure and increase the leptin resistance, and result in leptin resistance and increase in ghrelin. And that then in turn leads to obesity. So you end up with a vicious circle going around. And so when we see a patient with obesity, I think we need to think about whether they have sleep apnea. And the reverse is also true. When I see a patient with sleep apnea, I have to think about whether that's actually leading to obesity, and therefore treating sleep apnea may be able to alter all of these factors and try to break the vicious circle. Okay. So what about weight loss as a treatment for obesity? Now, we know weight loss as a treatment for OSA. Now, we know by treating patients for their OSA with CPAP, the patients don't actually usually lose weight. And in fact, the literature suggests that if you sort of say, let's just treat your sleep apnea, maybe your weight will improve, the data suggests they will gain a couple of kilograms. So with this study, which is published in Sleep Medicine in 2004, what they actually did is they had two groups of patients, and one group, they randomized them to CPAP for 6 months, and then followed by VLCD for 6 weeks and CBT for 24 months. And for the other group, which is called the non-CPAP group, they just gave them VLCD for 6 weeks and then CBT for 24 months. And this group of patients had a mean weight of 140 kilograms at baseline, and both groups actually achieved 9% weight reduction at 2 years, although they're starting to gain some weight. And they defined the therapy success as a reduction in oxygen desaturation index of more than 50% and subjective well-being. And in this particular study, 20 out of the 29 patients actually maintained at least 5% weight loss at 3 years. And what you can actually see here is that at six months, the patients who have gained weight or lost 0 to 5 kilograms, virtually there was no treatment success of their sleep apnea, whereas those who have lost somewhere between 5 kilograms plus have had some success, and the more weight you lose, the more success they are at reducing OSA severity. But at 24 months, these patients, the rate of success has decreased because they are starting to gain weight. Oh, sorry, wrong way. But treatment with CPAP alone does not actually result in weight loss or improvement in cardiometabolic risk factor. And this is quite an elegant study shown by this paper in the New England Journal of Medicine in 2014, where what they have shown is they divided the group into those who just got CPAP and those who got weight loss alone, and also those who actually got both. And we know that in this study, the weight change at 8 weeks with a CPAP alone is actually plus 0.3 kilograms. And at 24 weeks, it's plus 0.7 kilograms. So the CPAP group had a small weight gain. But for those who were randomized to weight loss plus CPAP, there's a weight loss of 3 kilograms at 8 weeks and 7.1 kilograms at 24 weeks. And similarly, for those who are randomized to weight loss only, there is a weight reduction of minus 4.4 and minus 6.9. And what actually happened with this is you can actually see that the patients who had weight loss plus CPAP, which is in the orange, has the greatest change in insulin sensitivity. And they also had the greatest weight loss, greatest reduction in serum triglyceride levels. And so there's no doubt that if you can combine weight loss with CPAP therapy, you get the greatest benefit in control of cardiometabolic risk factors. I want to spend the last few minutes discussing obesity hypoventilation syndrome. And the reason I want to do this is I think this is often missed by many doctors, even in the emergency department. And there are significant consequences for missing something like this. So obesity hypoventilation syndrome is actually pretty simple. There are actually only 2 diagnostic criteria. You have to show that the person has obesity, and you have to show that they're hypoventilating. So hypoventilating is defined as other sleep-related hypoventilation or awake hypercapnia. Usually it's you would have to have an arterial CO2 of more than 45 millimeters mercury. And all for the patients who has obesity hypoventilation syndrome usually will have a sleep-related hypoventilation because the controlled ventilation is weakest during sleep. So if you're going to hypoventilate, the first place where you start hypoventilating is during sleep. And that the definition of sleep-related hypoventilation requires a sleep study with transcutaneous carbon dioxide monitoring and is defined as CO2 going above 55 millimeters mercury for more than 10 minutes, or an increase of 10 millimeters mercury for more than 10 minutes to a level that's above 50. And this is a diagnosis of exclusion, and you diagnose this in absence of alternative neuromuscular, mechanical, and metabolic explanation for the hypoventilation. So most studies suggest that 8 to 20% of those referred to sleep clinics have obesity hypoventilation, and the prevalence increases with increasing degree of obesity. And the prevalence of obesity hypoventilation syndrome is actually similar in males versus females, but the females develop obesity hypoventilation syndrome at the older age compared to males at the time of diagnosis. The delay in diagnosis or misdiagnosis are quite common. Nearly 75% were misdiagnosed and treated for obstructive lung disease, even though there's no evidence of obstruction on lung function testing. And undiagnosed obesity hypoventilation syndrome is associated with increased healthcare utilization. So if you look at a collection of 757 patients from 15 studies about obesity hypoventilation syndrome, what do these patients actually look like? So this is done by Balachandran back and published in Sleep Medicine Clinic in 2014. And as you can see here, that in this cohort, the average age is about 52. There are about 60% of them were male, and the mean body mass index is 44. Most of these patients have quite a large neck with a neck circumference of 46.5 centimeters. The pH is 7.38, and CO2 is about 53. The interesting thing here is the mean bicarbonate is 32. And so usually the bicarbonate is elevated, and many have a very severe sleep apnea with a mean average apnea hypopnea index of 66. And you can see here the spirometry shows a mildly restrictive pattern, and many of these patients has excessive daytime sleepiness. So what are some of the other features that I could see on the sleep study? Well, if you do a sleep study on patients and you look at their oxygen saturation, what you will see is there's a significant difference in the time during the night where the oxygen level is less than 90%. So in patients with obstructive sleep apnea, they're hypoxic, but they're hypoxic was, for usually less than 10% of the time during the sleep study. And if you start to have sleep-related hypoventilation, the time in the percentage of time in bed that's spent with the saturation of less than 90% increases, and this becomes even higher with obesity hypoventilation syndrome. And the reason this is happening is because these patients has diminished hypercapnic ventilatory response, so they are not responding to hypercapnia with increasing ventilation. So why is this important? Why do I want to know, or why do I want all of you to know? And the reason I want all of you to know about OHS is this can lead to high all-cause mortality if untreated in observational studies. And the mortality has been reported as high as 18% at 1 year if they have acute and chronic respiratory failure, and 31.1% at 3 years. And this is associated with increased healthcare utilization, and that leads to more to physicians, higher healthcare cost, more hospitalization, and these can all be decreased after diagnosis and treatment. So what I'm asking you guys to think about obesity hypoventilation syndrome. Think about whether the patient in front of you who keeps complaining of some minor respiratory sort of, symptoms could have this, and it is undiagnosed. And if you can identify them, particularly if they have a high serum bicarbonate, send them to me and I'll fix it for you. And we know that survival actually improves once you treat the obesity hypoventilation syndrome. So if you treat the obesity, if you have untreated obesity hypoventilation syndrome, the probability of survival does decrease quite a lot. And you can see by 12 months, quite a number of them are no longer with us. But if you treat patients who have obesity hypoventilation syndrome with positive airway pressure, then the probability of survival is actually, you could argue, it becomes better than those who have normal CO2 with severe obesity. So this is definitely worthwhile treating obesity hypoventilation syndrome. So what would I like you to take home from this? Well, ask some sleep questions when you see a patient with obesity. Consider all who present with unexplained dyspnea, unexertion, and hypersomnolence. And most patients have loud snoring, nocturnal choking episodes, and witness apneas with daytime sleepiness and morning headaches. And most have hypoxia during wakefulness. So if you have a pulse oximeter, you'll find that often their sets is, let's say, 94%. And you'll find that the serum bicarbonate is more than 27 millimoles per liter. And if you get a sleep study, then the time with oxygen saturation of less than 90% is quite high. And ultimately, the diagnosis requires an arterial blood gas sampling during wakefulness and exclusion of underlying diseases that may cause hypoventilation, which is what we'll do in a sleep clinic. But if you can actually identify the patient who are hypoxic or have a high serum bicarbonate who are sleepy and send them to us with a referral letter that says, I think this patient has OHS, then they will get prioritized and we'll see them and we'll treat all the respiratory failure and stop them from coming to the hospital. And so in summary, breathlessness is a common complaint in obesity, and it is often multifactorial. Pulmonary physiology changes with increasing obesity can actually be difficult to distinguish from pathology. It is important to ask about sleep symptoms when you assess a patient with obesity. And weight management is an important element of sleep apnea management in addition to CPAP. And hopefully I've shown you how to identify and treat OHS early, and this can improve outcomes. And finally, I would like to sort of remind me that as medical practitioners, we need to actually support all 4 pillars of wellness, and that includes nutrition, the mindset, sleep, and exercise. And thank you. And if you have any questions, please submit them, and we'll try to see if we can discuss some of these at the end of the session. Thank you.
Thank you so much, Carol. I found that really interesting. Very disappointed to hear that improving sleep doesn't aid in weight loss, because that doesn't quite seem fair, that gaining weight causes problems with sleep. So it should be, if things were just, then the converse would be true as well. So yeah, I'm sure there'll be lots of questions, and I've got questions as well. We'll move on to our second presenter, Dr. Richard Singer. Richard is a renal physician at the Canberra Hospital Renal Unit and in private practice at RSCM with Carol. His main interest is kidney disease and nutrition, with a focus on the impact of nutritional deficiencies and excess body weight on health. Richard also has SCOPE certification. He's the medical lead for the Canberra Hospital Renal Weight Management Program and the Canberra Hospital Chronic Kidney Disease and Home Dialysis Programs. Richard will be talking about the impact of obesity on renal function and approach to fatty liver and the more severe condition NASH, or non-alcoholic steatic hepatosis. I think I've said hepatitis. Sorry about that. So over to you, Richard. And Richard's also got some fabulous artwork in his slides tonight, which we'll all appreciate. So thank you very much, Richard.
Thanks very much for that kind introduction, Leonie. Saying the whole of NASH is a bit of a tongue twister, and a few things to do with the kidney are tongue twisters as well. But thank you for that, and thank you to CHN for inviting me to come and speak. I just want to disclose I have previously received speaking fees from Boehringer Ingelheim, who, amongst other drugs, make empagliflozin. So what I'd like to tell you about today are pitfalls in interpreting eGFR in patients with obesity, and an approach to albuminuria in patients with obesity. Now, unlike Carol's talk, patients with kidney disease don't come to you with symptoms, not until they've lost about 90% of their function. So what I'm talking about largely is asymptomatic disease that's going to rely on you to pick it up and treat appropriately. And then finally, I'm going to talk about an approach to non-alcoholic fatty liver disease from the perspective of a renal and obesity specialist. And mostly I'll talk about diagnosis and referring on. But before I jump into my main slides, I just wanted to put up a couple of patients. And you can see that these 2 patients who I have invented both have exactly the same age. They're both male. One has class 2 obesity and one is of normal body weight. One has some albuminuria and the other does not. And otherwise they have identical creatinine, identical eGFR. But because they're going for nephrectomy for cancer, they actually have a measured GFR. And it is important sometimes to think about the difference between what the actual GFR is and what the estimated GFR is. So the eGFR is the one that we get reported on all of our EUC tests automatically. That's the eGFR. The measured GFR is what you get from an exogenous marker. So traditionally it would be inulin. In Canberra, it's all DTPA. In other states, they use EDTA and other markers. So in this particular case, the measured GFR for this person, patient 1, is much higher than their eGFR. The measured GFR for patient 2 is much closer. And just have a bit of a think as we go through the subsequent slides. Which person do you think has the worst long-term renal prognosis, both before and after their nephrectomy? Now, to help in your cogitation about that, let me tell you a bit about creatinine. So creatinine is something we measure, and certainly I measure all the time. I don't think it's rare that a patient comes to see me without having had creatinine measured in the previous few weeks. But it comes from meat or flesh, and it also comes from creatine powder if you're a bit of a gym junkie. So both red meat, white meat, and fish. There is some day-to-day variation in how much creatinine your body puts out and produces, and there's also a variable amount that's secreted. And for the purposes of using it to calculate GFR, we don't want to know about this. Well, we don't want there to be a secreted amount. We are only interested in the filtered amount. So it's not a perfect marker, and I'll talk about that a little bit more as well as we go on. There's a lot of variation from one individual to the next in their creatinine excretion, but not all that much on a day-to-day basis within the individual. And so what is the impact of obesity on kidney function, both on measuring it and on what the actual kidney function is itself? So now you get to this high-priced artwork that Leonie alluded to. So this person represents someone that is of normal body weight with 2 normal kidneys, and they're on a normal diet. I've represented their normal muscle mass with this, which arguably, it's not my arm, but arguably that is not a normal muscle mass, but let's say it is, and a normal diet, in this case consisting of a rack of lamb. So their muscle and their rack of lamb will pour in creatinine at this end and raise the blood creatinine level. They have normal kidneys, so they get around about 500 mils a minute of plasma flowing through their kidneys. And then they have a filtration fraction, in this example, of about 20%. So 400 mils per minute of plasma flow out the other end, and the other 100 becomes the GFR. Now, the actual normal filtration fraction from one individual to the next can be anywhere from 10 to about 25. So it is an arbitrary thing for me to say 20. The creatinine that they produce and eat raises their creatinine. The GFR lowers their creatinine. And as I mentioned, some creatinine is secreted. So that's the 8% coming down there and adding to the GFR. Now, that's why a creatinine clearance, a measured creatinine clearance, is always going to be higher than a measured GFR. And it's also why in patients with obesity, it's a mistake to think that you can measure the creatinine clearance and get a more accurate representation of their kidney function. You may in some cases, but there are a lot of traps in doing that. So now, still with the highly detailed artwork, so we still have a normal body weight person with normal kidneys. They have the same musculature, but they're actually now a vegetarian, so they're going to enjoy this nice piece of kale. So their creatinine coming in this end, it will be less because they're no longer eating anything that actually contains creatinine or creatine. So their plasma creatinine will be a bit lower. They have normal kidneys. They've got the same number of filters in the kidney, same number of capillaries. So the plasma flow through the kidneys will be about the same, still 500 mils a minute. But because of the effects of meat and fish on filtration fraction, they're likely to have a lower filtration fraction than the person who consumes more meat. So rather than having 400 come out on the right-hand side, I've put down only 430. And that means their GFR is lower. So their GFR will be 70. They will still have some creatinine secretion. So the measured creatinine clearance, if you did it, would be higher. But they have reduced kidney function. Now you look at somebody who has developed obesity, but they have normal kidneys. So they're quite healthy, except for their obesity. Because of the obesity, they have more muscle mass as well. And as people lose weight from obesity, they lose muscle mass. As they put on weight with obesity, they do gain some muscle mass generally. Most patients with obesity have a relatively normal diet, so the amount coming from diet is going to be similar. But overall, there'll be more creatinine pouring in at the top. So the plasma creatinine will tend to be higher in patients with obesity. They also have more creatinine being secreted, which will tend to lower the plasma creatinine somewhat and to a variable extent. But the effect of obesity on the kidney is to promote hyperfiltration. The reason why it does that is unclear, but it certainly does do it in many patients with obesity. So you have the 500 mils a minute of plasma coming in, and now you've only got 350 coming out. So you've got this huge GFR in the example of 150 mils a minute. And of course, with the creatinine secretion, their measured creatinine clearance would be higher. And the effect of that high pressure in all the filters of the kidney is to stretch the filter, give it little holes, and allow more leakage. So you'll get more albuminuria. So it's much more common to see albuminuria in patients with obesity. And if the obesity goes away, often the albuminuria will improve or even go away itself. Unfortunately, this person didn't manage to lose weight and didn't have that much treatment. So as the obesity continues and that high pressure in the kidney continues, you end up with scarring and loss of glomeruli. So loss of filtration units, loss of capillaries within the kidney. And inevitably, that's going to reduce the amount of plasma that flows through the kidney. So this person still has a high filtration fraction. So they still have what looks like a normal GFR and is a normal GFR, but it's actually hiding the fact that there's quite a bit of scarring that's happened. And as time goes on, they lose more filtration units. In the diagram on the right, the plasma flow falls now to 250, still with the high filtration fraction, but now they actually have a reduced GFR. So the GFR here is quite similar to the one I gave in the example of the vegetarian. But the big difference is here, it's in a background of a lot of glomerulosclerosis, a lot of glomerular scarring, and maintenance of that kidney function by hyperfiltration. So the person has damaged their kidney quite significantly, whereas the vegetarian has not. I'm not saying that the vegetarianism is necessarily helping the kidney all that much. I'm just making the point that the GFR alone doesn't necessarily tell you how bad the internal structure of the kidney is. Now, when we talk about a GFR or an eGFR, we usually correct it for body surface area. So when they're reported on the EUC, it will always be in mils per minute per 1.73 square meters body surface area. And that sort of makes sense. You know, if somebody's 1.5 meters tall, they're not expected to have arms the same length as someone who's 2 meters tall. And someone who's smaller doesn't need kidneys that are as big and powerful as someone who's bigger. That makes sense. And most of the body surface area does come from height. But weight has its own contribution. And as weight increases, it will increase the body surface area. So if you have someone with a particular GFR and they gain a lot of weight, even without a change to the GFR, the reported one, corrected for body surface area, will fall and make it appear that they've lost kidney function or that they have low kidney function. That's not usually a problem when you're looking at eGFR. But it is a problem when you are looking at measured GFRs. Now, most of you, I'm guessing, don't measure GFR very often, if at all, but you will occasionally be looking after patients going for nephrectomy, and you may get that DTPA measured GFR come back, and you're thinking, well, do I look at the one corrected for body surface area or not? And if you have someone that is particularly heavy, you're probably better off looking at the uncorrected one. So diet, exercise, and obesity all affect the GFR. So if you have a heavy meat intake, that will produce a lot more creatinine. If you're like the person on the right and you're having a vegetarian diet, you'll tend to have a lower creatinine. If you have a lot of muscle because you do a lot of working out in the fields or the gym, creatinine is higher. If you have a sedentary job, creatinine is lower. But when we estimate the GFR, we don't know any of that when we're looking at the reported eGFR. So what we actually look at is only the age, the sex, and the plasma creatinine. There's no information there on body habitus. There's no information there on diet. And the purpose of correcting for age and sex is simply to correct for factors which alter the plasma creatinine without altering the GFR. So when people are older, they generally have less muscle, So we want to correct for that in terms of thinking whether a high GFR means that they've got high creatinine means that they've got kidney failure or not. And females generally have lower muscle mass than males. But these are stereotypes, and it's very easy to think of an older person with more muscle than a younger person and a female with more muscle than a male. So we need to bear that in mind when we're looking at the output of this equation. And in fact, partly because these stereotypes are not always accurate, but also because there's not enough information there on diet and body habitus, the CKD-EPI equation is really not that accurate. It's the best that we've got, but that's not saying a lot. So in fact, the equation is accurate to within 30% of the measured GFR 80% of the time. And if you think about that, that means that if the actual GFR is 40, so the measured one, maybe with an inulin clearance, is 40, the estimated GFR that's reported can be anywhere between 30 and 50% in 8 out of 10 patients, 30 and 50 mils per minute in 80% of patients. And in 1 in 5 patients, it's going to be even further off the truth than that. And this is in patients who have a relatively normal physique and a relatively normal diet. If you move it and you're looking at patients with unusual body weights, either malnourishment or obesity or unusual diets, the equation becomes even less accurate. And added to that, I think it is important to keep in mind that a normal eGFR does not mean that the kidney is not damaged. The kidney strives to maintain GFR, and it manages to do so until it's lost sufficient kidney tissue that it's no longer possible. So if we go back to those cases I brought up at the beginning, what would I consider in terms of who has the worst renal prognosis? Well, the patient with obesity is likely to have the worst renal prognosis just on general epidemiology, but you need to consider muscularity. So if you didn't have the measured GFR, the muscularity of the patient would be important for assessing their plasma creatinine and therefore the eGFR. You need to have a think about how many glomeruli you think they have. Now, obviously, we don't know, but past medical problems such as premature birth or small for weight baby, small for date baby, or cardiovascular disease, those sort of things can reduce the number of glomeruli that they have. And then you want to think about how hard the glomeruli that they do have are working. And so into that, you need to think of diet. So a vegetarian diet, the glomeruli don't need to work as hard, and they won't be working as hard. A person that has overweight or obesity, they're likely to be working harder. And you can look for evidence of that by looking at the urine albumin creatinine ratio, which will often be raised in patients that are hyperfiltering. So obesity or meat intake increases filtration demand. And what I haven't mentioned before, but is important, is that a reduction in renal mass increases filtration demand. The kidneys cannot generate more glomeruli. You've got what you've got when you're born, and that's it. And they can't alter the filters. They can't become more efficient at filtering blood as you get older. So the only way they can respond to an extra filtration demand is by hyperfiltering. So the glomeruli that are left hyperfilter, and the way they do that is by raising pressure within the glomerulus. And unfortunately, higher pressure means higher failure. So albuminuria, more leaky, and ultimately scarring. And hyperfiltration is why kidneys donors don't usually halve their GFR. It usually only goes to about 70% of the previous GFR. And it's the reason why you can get very high measured GFRs in patients with severe obesity. And it's not a good thing. Now, I didn't want to make this too technical, and so I decided to put a little fairy tale in here. And the hero of this fairy tale is Leonie. So once upon a time, a long time ago, Leonie was living in a village that was starving. And fortunately for her in the village, this wild pig ran past. And so Leonie grabbed her spear and took off chasing this wild pig to catch it and save her village. But you know that pigs, or perhaps this is a warthog, I'm not sure, but we know that pigs are wily creatures. They're fast and they're strong. And poor old Leonie didn't manage to catch it straight away. She ran and sweated, became a bit hypovolemic, and of course then had a slight fall in her GFR. Now the kidney wants her to catch the pig. The kidney doesn't want her to fail in her mission and die. So whenever the kidney senses a fall in GFR, it does whatever it needs to do to bring it back up. And one of the ways that's sensed is that when the GFR falls, the tubular flow becomes slower because there's obviously less filtrate going through, which gives more time for sodium absorption, both in the proximal tubule and in the loop of Henle. Now, the end of the loop of Henle is the macula densa, and the macula densa sits there sensing sodium and chloride. And the more sodium that's reabsorbed proximally, the less sodium will be there at the macula densa, which triggers a relaxation of the afferent arteriole and a constriction of the efferent arteriole, which serves to maintain the intraglomerular pressure and therefore maintain the GFR. And so Leonie, when she caught the pig, has her kidneys in part to thank for keeping her mind working at peak efficiency and her muscles at peak efficiency. And I'm sure when she took the pig home and saved the village, they were all very pleased about it. Now, a similar thing happens in diabetes, but diabetes is a disease state rather than a state of hypovolemia. It's usually a state of hypervolemia, but the same thing actually happens, and it sort of tricks the kidney into the wrong response. And that's why I've put these down as a fairy tale maybe, or perhaps not a very exciting fairy tale, and some cartoon slides to try and help you understand, why the kidney does what it does, and therefore how it gets tricked in a disease state. So in diabetes, you have more glucose being filtered, meaning that there's more glucose in the proximal tubule. And that's generally completely reabsorbed, but it's reabsorbed with sodium glucose cotransporter, which everybody's heard about by now. So the more glucose there, the more sodium is reabsorbed, which means that there's less sodium when you get to the end of loop of Henle, and it sees the macula densa. So you have exactly the same situation as you had with Leonie the pig hunter. You have less sodium, which triggers relaxation of afferent, constriction of efferent, and a high pressure in the glomerulus, particularly because the blood pressure is often going to be high as well, unlike when Leonie became hypovolemic. So again, that will stretch the filter, higher pressure, more albuminuria, and ultimately, we believe, faster failure of the glomerulus. And you can use, for all states of hyperfiltration, you can use a sodium glucose transporter inhibitor, an SGLT2 inhibitor, which blocks that initial sodium and glucose reabsorption in the first part of the proximal tubule. And so whatever the cause of glomerular hypertension, it will ultimately deliver more sodium to the end of the loop of Henle at the macula densa, which leads to exactly the opposite thing occurring. So it returns it more towards a state of normality, not a state where the kidney thinks there's hypovolemia and a low GFR. Reducing the pressure in the glomerulus, lowering the GFR, less filtrate being produced, but also lowering the amount of albuminuria. And, in most of the studies, or all of the studies I've seen that have been done, helping to protect the kidney function in the long run. So what does this mean in overweight and obesity? What can and should we do about hyperfiltration? Well, the first thing to say is that SGLT2 inhibitors are not indicated for treating obesity. But the point that I'm trying to make by talking about them in this lecture is that they are useful in many patients with overweight and obesity to treat comorbidities that are common in that disease. So they have been studied in diabetes, glomerulonephritis, and both albuminuric and non-albuminuric kidney disease. And they're effective in all of them, although more so in the albuminuric disease. So when you have a patient with obesity, you need to go looking for albuminuria. And when it's there, you need to assess why it's there. One of the treatments that can help, along with ACE inhibitors or ARBs, would be to think about an SGLT2 inhibitor if they meet the standard prescribing criteria. So now we shift organs to the liver and talking about non-alcoholic fatty liver disease, or NAFLD, NAFLD. Now, NAFLD is divided up into two subgroups. There's NAFL, where the liver is just fatty but no inflammation, and there's NASH, where there is inflammation, so steatohepatitis. In order to diagnose it, you need to have at least 5% liver fat in the absence of other causes. The main other cause is alcohol, but I'll show you in another slide. There's a few other things to think about as well. Non-alcoholic fatty liver disease is incredibly common. It's very underdiagnosed, but the prevalence is thought to be about 25%, 1 in 4 Australian adults. By itself, it's fairly benign. It's when it converts into NASH, which is about 5% of the adult population, that it becomes more serious, and there's a risk of progression to fibrosis or even cirrhosis. So they think about 0.8% have severe liver fibrosis. Now, if you look at people with other risk factors, such as obesity or diabetes, the rate of NASH becomes much higher, so as high as 40% in patients with diabetes. And there is a lifetime risk of progression of about 1/3 from NAFL to NASH, and about 20% of those go on to develop significant fibrosis. NASH is now one of the main causes for hepatocellular carcinoma, and the hepatocellular carcinoma tends to occur at lesser degrees of fibrosis, so it occurs even before people have developed cirrhosis, which is uncommon in other causes of cirrhosis. So to diagnose it, you need to have hepatosteatosis, which you will pick up usually on imaging, so often a liver ultrasound or a CT of the liver. Many times it's done for other causes, or it might be done to assess for abnormal transaminases. You need to exclude significant alcohol consumption. Now, what that means, I guess, is up to you. There is no strict definition of it. Most people would put it at anything more than the guideline recommended alcohol, so 1 or 2 standard drinks a day. And then you need to exclude other causes of steatosis. Pregnancy is not challenging to diagnose, is usually pretty obvious, but other things can be a little bit more obscure. So it's important to review the medications. And I've listed a few there that are associated with steatosis. And the way that they're believed to cause the steatosis is by impairing fatty acid oxidation in the liver. And when the liver can't oxidize its fatty acids, you end up with them accumulating. And of course, that causes steatosis. The other thing that you need to exclude is some other coexisting cause of chronic liver disease, hepatitis B, hepatitis C, and all those rarer autoimmune liver diseases. The important thing is to work out who has NASH, because that's the disease that progresses. And this is difficult. It can only be done really, certainly, with a liver biopsy. But you can't be going around biopsying 20 or 30% of the adult population. And the problem with a liver biopsy is there is quite a bit of inter-observer variability in the reports, and you've got sampling errors. So most people will never get a liver biopsy. You look at the degree of transaminitis. That does not predict the degree of inflammation or fibrosis very well, but if it's there, then they're more likely to have NASH. And it's worth making the point that in a large American primary care study, most patients that had moderate to severe liver fibrosis from NASH actually had barely elevated transaminases. They were mostly less than 40. You can also look at the AST-ALT ratio. Most liver diseases, the ALT gets higher, but in alcohol, you tend to get more AST. And so if you have a ratio of more than 2, that's suggesting to you that this may be alcohol-related liver disease rather than non-alcohol-related steatohepatitis. The most recent guideline for diagnosing and managing NAFLD and NASH is from the American Endocrinology Association, came out last year, and that was in association with the Association for the Study of Liver Diseases. There's a guideline that's somewhat difficult to use. it does have some changes from the 2013 RACP guidelines, certainly a greater emphasis on the liver FibroScan. So the first thing is imaging to find out if they have fatty liver disease. And then in anyone with fatty liver disease, doing a screen using the FIB4 equation, which I'll show you in the subsequent slide. That just involves measurement of AST, ALT platelets and knowing the patient's age. And then based on that FIB4 equation, they suggest going on to do a liver FibroScan, which is simply a form of ultrasound of the liver, looking at how stiff the liver is. In those with a high FIB4, you would do a FibroScan, but they also say that anyone with obesity, metabolic syndrome, diabetes, or persistently abnormal transaminases, you would do a FibroScan. And that's why I think the guideline is not as useful as it could be. But unfortunately, that is the state of our knowledge at the moment. Now, they do suggest doing a low FIB4 calculation, but it's worth remembering, much as the fact that a lot of people with minimally raised transaminases can have severe scarring in the liver. There are cohort studies that show that the majority of patients, I think it was 65% of patients who went on to develop liver cirrhosis over the subsequent 5 to 10 years, actually had a low risk FIB4 score. So you can do the score. If it's high, that definitely promotes some action. But if it's low, you can't be completely reassured. And this is how the FIB4 score is calculated. So age times AST divided by platelet divided by square root of ALT. And you can calculate it yourself, or if you Google it, there's a whole lot of online calculators that you can just plug the numbers into. It does require an AST, and some of the local pathology units don't give that to you unless you specifically request it. I'm thinking mostly of ACT pathology there, but I think I've seen some of the others not reporting it as well. That FIB4 score ranges from 0 to 6. And if you're younger, then a score of more than 1.3, it should initiate a FibroScan. If you're older than 65, then the score's allowed to be higher before initiating the FibroScan. And there are several reasons to refer on to a gastroenterologist. So one, which everyone would not have difficulty with, I think, is if there's any stigmata of chronic liver disease, spider nevi, that sort of thing, splenomegaly, cytopenias, or in someone who has persistent and marked transaminitis. So I think that's just standard care. That's not teaching you anything there. With the FibroScan, which can have two components, one is a liver stiffness score, which is all I'm talking about. The other can give you an assessment of liver fat. So with the stiffness score, you get it on a 0 to 4 scale, and anything of 2 or above, which is the same as greater than or equal to 7.5 kilopascals in the actual measurements, should warrant referral to a gastroenterologist because there's a reasonably high chance that they have moderate to severe liver fibrosis. Now, much like the FIB4, the FibroScan's not perfect. You can get elevated readings in patients with a lot of liver inflammation that's unrelated to fibrosis, and in patients with liver congestion. So if you send someone along with heart failure, you're not going to be able to interpret it very easily. Added to that, it's more difficult to do in patients with obesity. And that's exactly the group that you're wanting to do most of them on. So while you may be able to rely on the reading when you get one, the chance of a failed reading is higher in the obese because they can't get a consistent measurement. When they do this, they usually do 10 readings and then they work out what the spread of readings is in terms of deciding whether the test is valid. Overall, though, it's about 80% sensitive and specific. So if the F2 is greater than or equal to 2, it's actually pretty good for telling you that they have moderate to severe fibrosis and you should refer on. So NAFL is not a particularly serious condition, except in the way that it goes on to turn into NASH. So the treatment for that is really lifestyle related and trying to manage weight. But once people have developed NASH, it's worth considering whether you want to use drug treatment. There isn't any drug in Australia or anywhere in the world probably that's licensed for treating NASH, but there are a couple of classes of drug that have evidence of benefit. So one of them is the PPAR gamma, pioglitazone, which I personally would really hesitate to use given its other potential adverse effects, but it does have data on improving NASH. And the other one, which I think is a lot easier to use, especially now you can actually pick some up at your pharmacy again, which is GLP-1 agonists. And most likely, I think they work by lowering body weight. The mechanism for pioglitazone is probably more complex. In terms of what I'm hoping you'll take away from the GFR and obesity component of the talk is to remember that obesity does affect the eGFR and the measured GFR, sometimes in the opposite direction, and albuminuria. And we've got to acknowledge that it can actually be difficult sometimes to work out who has mild or even moderate chronic kidney disease. The patients certainly won't complain about it, and it does take a bit of extra effort from us. But it's well worth working out whether patients do have mild or moderate CKD, because it makes a big difference to how intensively you're going to manage their risk factors for progression. And finally, I think it's very important for you to be able to distinguish or have a method of trying to distinguish between a fall in GFR from a loss of renal tissue, which is always bad, and a fall in GFR due to a fall in filtration fraction, which actually is often good. Now, with the liver, NAFLD is incredibly common. It is a rising concern with the rising obesity and diabetes. It is important to screen for fibrosis. I acknowledge that it is difficult to know exactly what to do in the individual patient, but I think we need to have a high index of suspicion for the presence of NASH and to be prepared to send people for at least a fibroscan, which is fairly easy to obtain, with a view to referring on when we're concerned. And you can't be completely reassured just because the transaminases are only mildly elevated. Thank you. I shall now stop sharing.
Thank you, Richard. I appreciated the story and I thought your artwork was exemplary. So we'll move on to questions now. And because I'm the host, I get to ask the first question. So just the first question for you, Richard, is how do you feel about the quite a common scenario of people with type 2 diabetes and obesity going on the high protein, low carb diet and its impact on the kidney in terms of just increasing the protein load?
So, I mean, the kidney guidelines, so that in the question, the person doesn't have chronic kidney disease yet, or they did?
Not yet.
No, not yet.
Yeah.
It's going to happen to everyone eventually, isn't it?
Yeah.
So, well, if they don't have chronic kidney disease, then I don't have any particular concern with a high protein diet. If someone did have chronic kidney disease, then the renal guidelines often still recommend a degree of protein restriction. But I don't actually know any nephrologists that agree with that. The primary study, the MDRD study for protein restriction was a negative study. It's only the post hoc analysis that really showed a benefit. And it actually makes a big difference, probably makes a big difference where the protein comes from. So meat, fish, they increase your GFR, they cause hyperfiltration in the studies that have been done. Whey, appears not to. Soy probably doesn't. So those vegetable origin proteins or perhaps milk origin proteins are unlikely to be, I think, or much less likely to be damaging to the kidney. So I don't have undue concern about it.
Right. So maybe vaguely, if you're going to go for the high protein diet for weight loss, you'd be thinking potentially about trying to emphasize vegetable proteins rather than meats.
Yeah, I mean, there's a lot of theoretical data to say that vegetable proteins are better. There's not really any, randomized evidence to support it. But it would make sense that vegetable proteins are safer for the kidney.
Right. Okay, thank you. So now we'll move on to some of the questions posted. So our first question, I think, is for you, Carol. So a question about sleep apnea without obesity. I have a very slim patient who is convinced they have sleep apnea, no apparent symptoms, but seeking assessment. Are you able to comment about sleep apnea in the very slim or normal weight population, please?
So I think it was one of the slides I have shown, weight probably contributes to about 50% of airway collapsibility, but there are a number of other things that can also affect the airway collapsibility. So if you are born with a very narrow throat, then the airways are much more likely to collapse, and often that's genetic. And so, and they're the patients where you look in the back of their throat and all you see is the hard palate. You can't see the soft palate. You can't see the posterior pharyngeal wall. And when you see something like that, then understandably, there's probably a high likelihood they may have some problems with breathing during sleep. And often these patients have significant family history of obstructive sleep apnea. And then there are other things that can probably make people more likely to have sleep apnea that you might want to look for. If they've had chronic bilateral tonsillar enlargement, then their airways are compromised, they're much more likely to have a collapsed airway. And there's some ethnic differences, I believe, in sort of like airway caliber and narrow throats. And usually I find that Asians, East Asians and South Asians are much more likely to have a narrow throat, and many are, were never obese but snores terribly. But usually if a patient comes to say, look, I really need to have wanted to have a sleep study, then I guess one will have to sort of discuss with them why they're seeking assessment, what are they worried about, is there anything else that they haven't actually told you, and and it's important to try to understand from their point of view why they were insisting on having a sleep study.
I think that also I was thinking about, there's quite a few children now who are, we're recognising sleep apnea in children and the role of large tonsils and adenoids and addressing that early on so that they don't grow up to be adults with sleep apnea and poor sleep.
Well, children should not snore at all. For children to snore is pathological, and there's good evidence there to say that if you leave the sleep apnea in children untreated, it actually sort of impairs their ability to learn and development. So that's actually really important. And when you see children who are snoring, then that needs to be assessed further.
Yep. So we've got another question on sleep apnea. As in obstructive sleep apnea, any features or signs of hypoventilation syndrome just on examination and by questionnaires interviewing the patient which raised the suspicion of hyperventilation syndrome? So I guess in the primary care setting, if we don't have a bicarbonate level, what kind of tweaks our suspicion for hyperventilation syndrome?
Well, I guess you can look at what they had in the Pickwick papers, isn't it? I mean, that's a good description of obesity hypoventilation syndrome patients. So these patients are often quite somnolent. They often complain of poor quality sleep. They wake up with a headache, and they're often quite sleepy, or they complain that they have a difficulty concentrating, or their brain's not working properly, they're not thinking properly. I mean, the highest carbon dioxide that I have seen in a working patient who turned up to have a sleep study is 90 millimeters mercury. And the upper limit on normal is 35 to 45. And this particular patient works in a fast food restaurant, and has been doing so for quite some time. And her colleagues thought that she was hilarious. She can actually fall asleep while making a sandwich.
Did she have a flap or anything like that? Did she have a?
No, I mean she was working full time. She sort of wanders around, and and then she had her sleep study, and in the morning we had a CO2 of 90, and and we almost fell out of our chairs and go, what are we going to do now? So but having hypoventilation is actually detrimental to health, and even a small rise in carbon dioxide can significantly impair the cognitive ability of patients. And some years ago, I had a patient who we've been treating for OSA for a long time. And then one day his CPAP machine broke, and he came and asked me to have a look so he can buy another machine. And so we did a sleep study trying to see where things are. And he had a daytime CO2 of about 48 millimeters mercury. And now normal is 35 to 45. So you sort of say, well, that's kind of a borderline. And so we discussed that, will we go to a bilevel ventilator versus a CPAP machine, because a bilevel ventilator is 3 times as much. And he says, look, I can only afford to buy one machine, and I have to get it out of my superannuation fund. So we and ahh'd for ages, and he decided that he will purchase a bilevel ventilator. And then a few months later, he came back, and I asked him, how is your bilevel ventilator? And he goes, oh, this is fabulous. I love it. And I sort of said, so why do you love it? And this guy worked at the IT help desk. And he says, look, since I started using this machine, everything is easy. When people ring me up to ask me to fix their computer problems, it's sort of like the solutions are just so obvious. Whereas before he started using the machine, he was compliant with his CPAP. He just couldn't actually come up with the solutions. Right. So a small improvement in carbon dioxide level can result in significant improvement in quality of life and ability to function.
Yeah. What's your experience with the mandibular advancement splints? Are they like the SomnoMed ones and the the expensive ones that dentists make?
Yeah, so the mandibular advancement splint has been trialed only for obstructive sleep apnea. There's actually no evidence for its use whatsoever in obesity hypoventilation syndrome. Yep. And patients who benefit most from mandibular advancement splint are typically patients who might be overweight or may have class 1 obesity, but also the patients who have mild to moderate sleep apnea. So for most of the ones I see who have class 3 obesity and severe sleep apnea, they wouldn't be first line of treatment.
It's not enough. Yeah. Okay, we've got another question here for Richard. So I hadn't realized the eGFR variation. So what are the positive reasons for retaining eGFR as a routine assessment?
So I didn't mean you to think, if you took that impression, that the eGFR is a waste of time. I mean, you need something that's cheap and repeatable and accurate enough. And the eGFR is cheap, it is repeatable, and it is good enough almost always. But when you look at the number, it doesn't mean that's actually what they have. So it's more important to, if you have someone that has, say, a mild or sometimes moderately reduced eGFR, to think about whether it's due to their diet, their shape, other things, and to look at the trend. So whether it's increasing or decreasing. The GFR can easily jump up and down by 10 from one visit to another in someone with CKD, and it doesn't really mean anything. It's more if you're seeing a steady decline. So, in some patients, we start dialysis with an eGFR of 14 and they have a lot of symptoms. And I have others, the lowest I started was 3 for chronic kidney disease, who reckon she didn't have any symptoms. I think she probably did, but they certainly weren't, that severe. And I think the reason for that is probably that the GFR's not that precise. Like when it says it's 3, it could be 8 or 10, and when it says it's 10, it could be 15 or it could be 6 or 7. So it still gives you an idea of what you're looking at, and I think it is still a very useful test.
Yeah, and in combination with a spot urine albumin or something like that. Yep.
Yeah, because the albumin is what tells you how fast it's likely to deteriorate.
Yeah.
The eGFR is likely to deteriorate.
So speaking of mobility, I think you mentioned before we started that the FibroScan is quite accessible and quite affordable for GPs to order. So could you just let us know about that?
I don't know exactly what they charge for it, but I think it's roughly the same cost as just a normal liver ultrasound. And certainly when we were chatting with some of the radiologists, they were very happy to do it, on request. There's certainly no restriction on ordering it.
Yeah.
Whether they'll be able to guarantee to give you a result in the person who's got a lot of subcutaneous fat over the liver is another matter. And I think it would be worth remembering that issue with liver congestion or acute hepatitis in terms of interpreting the result as well.
Yeah. Okay, I think we should probably wrap up because we've gone a bit over time, but that was so interesting. So thank you both very, very much. And we've also got Dr. Louise Brightman here with us as well on the panel. So thank you for being with us as well, Dr. Louise. Just to reiterate, if you'd like CHN to upload your 1.5 hours of CPD, send us your RSCG number and also complete the evaluation survey and send it back to us by the 10th of August. We've got the 5th webinar on the Thursday, the 7th of September. So save the date for that. And that's Dr. Louise Brightman and Dr. Deborah Inman on post-bariatric surgery, long-term care and complications. And we will be putting up the resources, the presentation slides and YouTube recordings shortly. So look out for them. And thank you again both very much for your really interesting presentations. Thanks and good night.
Thank you, Leonie.
Thanks.
Thank you.